welcome everyone to this webinar, which is hosted by BrainFacts.org and with the tremendous support of the American Brain Coalition. And our topic today is the neuroscience of pain, and our hope is to provide some background to the science of pain, the biology, what causes it, some introduction to approaches to pain management, how certain drugs work, and also address problems related to pain in the clinic, and as well as issues of advocacy and funding. We're very fortunate to have three, including myself, folks to talk to you today. I will be talking initially about the science. This will be followed by Michael Robotham, who is a professor of anesthesia and, as you can see, a neurologist who has a long-standing interest in the pain patient and deals with pain patients and management of pain patients, as well as in clinical science, where he's the scientific director at the California Pacific Medical Center in San Francisco. And then Kristen Veasley, who co-founded and is the director of the Chronic Pain Research Alliance, which is a major advocacy group for increasing funding and awareness of pain and pain research. And we hope to give you a strong background in these different areas in a rather brief period. And this will be followed with an opportunity to submit questions that we hopefully can provide some answers. We can't provide all answers, but we will certainly do our best. I wanted to begin with this slide, which really introduces somewhat of an anomaly. What the slide shows is the difference between how much money the NIH, the National Institute of Health, which is the major funder of pain research in this country. There are others, the Department of Defense, the CDC, and of course many places around the world that fund pain research. The difference between what the NIH spends on research and what the societal costs are of the particular problem. And there's a remarkable dissociation. If you look, for example, at cancer, now everyone realizes that cancer has an enormous impact on people's lives, and there's approximate $2 billion of expenditures on, no, I have this backwards, I'm sorry. The societal costs for cancer are of the order of $200 billion, and yet the NIH funding for cancer research is on the order of $5.5 billion. Now look at pain, where the societal costs are enormous, and the Institute of Medicine published a major report finding that perhaps up to 100 million Americans experience pain during the year. Maybe 25 million have severe pain that's debilitating, and yet the amount of money that is expended for pain research by the NIH is less than $500 million. And the question is why? And the real answer is what is unique about pain. Pain is a subjective experience. You experience it yourself. It's not a stimulus that occurs. It's a perception, and it can't be seen. And I think that's a major feature of the unique pain experience. You can see other diseases. You can tell somebody that is suffering from cancer. You can tell someone who's paralyzed, someone who might have an arthritic condition and they have trouble walking. But you can't see pain. Rather, pain is characterized by three major features. There's a sensory discriminative component. Where is the pain occurring? How intense is it? It's in your hand, it's in your leg, it's in your arm. But most importantly, there's an affective or emotional experience. Pain hurts. It's unpleasant. It affects your life. It affects your ability to work. It affects your ability to think. And of course, there's a cognitive component that the setting in which you experience the pain is so powerful. These are the important features, none of which you can see in an individual who's suffering pain. And so the question is, what causes pain? This is a slide that the people in the pain world like to show. Descartes, many years ago, wrote about pain, and this illustration is a classic one where he basically said that pain is like an old telephone system with a wire, where if you burn the foot, there's a wire that connects up to the brain, and poof, you get pain. This seems overly simplistic, but surprisingly, it's not all that different from what we actually teach students these days, or what the textbooks teach students. What the textbooks say, and what we've illustrated here, is the nervous system from the spinal cord at the bottom all the way up to the brain on the top. And what happens is when a pain fiber, if you will, in your arm or your leg gets activated by an injury stimulus, the information comes into the spinal cord and it travels up to the brain, and poof, you get pain. This looks just like the Descartes picture. In some respect, this is very accurate. It certainly illustrates how acute pain is generated. So there's a stimulus, it goes into the spinal cord, goes up to the brain, and ooh, that hurts. But acute pain is really not the clinical problem. The clinical problem is manifest as really two major types of pain. One we call is produced by tissue injury, illustrated rather emotively here in this individual with a severe arthritic condition. Yes, it looks terrible, the joints are distorted, but what's the real problem is that this individual is experiencing ongoing pain, and it even hurts to tie their shoelaces. So normally innocuous, non-painful stimuli hurt. That's one major category. And then there's another one that is particularly problematic because it doesn't respond to the traditional pain therapies that we'll talk about in a moment. These are called neuropathic pain, and they're caused by damage to the nervous system itself. This one is called complex regional pain syndrome, and you could readily see the difference, but this is an individual in the right leg, the right foot. It will be an ongoing pain, burning, and incredible hypersensitivity. Another example is postherpetic neuralgia. This is a woman who has been affected by a particular herpes virus that got into her nervous system, and even the lightest touch on her forehead will produce excruciating pain. It's illustrated rather dramatically. I was editor-in-chief of the journal Pain, and this is a sculpture of an individual, someone who has chronic CRPS, and he's illustrating what he is experiencing. Clearly, this is a subjective experience, and it's rather manifest dramatically in this image. So this is what we need to explain and understand. So how is pain generated? Let's begin with the peripheral nerve, basic neuroanatomy. So here's an individual holding a cup and lots of nerves, and we can see the brain. Now, when there's if we have a picture of what the peripheral nerves look like, what we notice is that there are different size nerve fibers in your arm or your leg. There's the large ones. These are myelinated. What it means is they have a sheath around them, and they conduct very quickly. They're involved in transmitting touch and joint position. And then we have small fibers that conduct more slowly, but these are the ones that actually respond to painful stimuli, and they're the only ones that respond to painful stimuli. So that's what's happening in your nerve. But what's most interesting is that these small fibers that only respond to painful stimuli can change their responsiveness so that in the setting of injury, they now will respond to non-painful or innocuous stimuli. So that the simplest example is somebody who has sunburn. Light touch, which normally is not painful, can now be very painful. So non-painful stimuli now hurt. That's actually one of the most common problems. And it's actually, we have a good explanation for how that happens. So we look at our individual again, and now let's see what happens when there's some tissue injury. Could be a burn, could be some muscle damage. This leads to the breakdown of tissue, and a chemical called arachidonic acid, the detail's not important, is synthesized, and this arachidonic acid is acted upon by a very famous enzyme, the cyclooxygenase enzyme, called the COX enzyme, which you may have heard even on television. This leads to the synthesis of another class of compounds called prostaglandins. And what the prostaglandins do is they actually act directly on the nerve fibers that have been affected by the injury, and the result is that their threshold for activation drops. So before they only responded when there was an intense stimulus, and now they'll actually respond to a rather non-painful stimulus. And that's a condition that is very common. It hurts when you move. That's a terrible condition. Or it hurts when you put clothes on. You have to put your clothes on all the time, but this is the problem. Some of these are actually readily, we can treat them, and you treat with a COX enzyme inhibitor. You just prevent this whole cascade, and aspirin and ibuprofen, the drugs that so many people take, this is how they work. And the idea is they reduce this whole cascade and return the threshold to normal. Now, is this relevant in other conditions? Well, yes. It's very likely that in many cases of back pain, knee pain, shoulder pain, this is what's going on. Now, unfortunately, the big problem is you can't necessarily give enough of the drug without having bad side effects, and so clearly we need new ways to treat the problem. But this is how this particular condition functions and how these drugs work. Now, one thing that we know, however, is that this picture is not surprisingly oversimplified. And what's important is that these small fibers that I talked about, they are not homogeneous. They're molecular biology research that has been funded by the NIH in particular has demonstrated the remarkable heterogeneity. Different genes are made by these different pain fibers, and among them are some that respond just to painful heat, and they actually respond to the capsaicin, which is the pungent ingredient in hot peppers. There's others that respond to menthol and to cold, and so there's a lot of specificity. And one of the things that drug companies are trying to do is develop drugs that selectively target these different types of molecules that maybe can produce a more selective regulation of pain. And then most excitingly on the horizon is the possibility of developing much more selective local anesthetics. Everyone knows that local anesthetics can completely block pain when you go to the dentist. And these are sodium channel blockers. But the problem is, of course, you don't want to eliminate all sensation. Well, it turns out that there's one subtype called NaV1.7 that may be a clue to a way to produce pain selective reduction. And rather dramatically, NaV1.7 came to the fore when it was found that there are individuals who have a mutation in the gene that makes this channel, and these people have no pain sensation at all. New York Times had a wonderful story about an individual who could experience no pain. That's not a good thing because acute pain is a message. However, it is worth considering that the drug companies might be able to target this channel in not a complete way and then produce remarkably selective pain relief without completely blocking all pain. That's one of the holy grails being studied by the industry. So where in the brain is pain? Again, we come back to the major features of the pain experience, and in fact, until imaging techniques had developed, we really couldn't get at this problem, but now we're starting to use imaging to be able to get a sense of what parts of the brain are activated when someone experiences pain. And the one thing we do know, there's no one pain area in the brain that you could cut out and eliminate pain. That's not going to happen. There are different areas and different aspects of the pain experience are engaged. And we come right back to our original discussion that there are different dimensions of the pain experience. The sensory discriminated, where is the stimulus? How intense is it? And certain parts of the brain, notably in what's called the somatosensory cortex, where your body is mapped, this is where different aspects of the location and intensity of pain are processed. But of course, as I mentioned, another major feature of the pain perception experience is the emotional or affective experience, what makes it unpleasant. If the experience is not unpleasant, then in fact there really is no pain. The unpleasantness is what makes pain so powerful. And it turns out different parts of the brain called the limbic cortex, these are different areas that light up. And then why is this important? Because the ability to monitor these areas might give us an approach to developing drugs that selectively take out the emotional component of the pain experience without eliminating the ability to detect the stimulus, because you do want to be able to detect it. So this is where some of the research is going. So let's go on to one other major approach to pain relief, namely the opiates, which are heavily in the news these days, and of course, for good reason. Now, one thing that needs to be stated, some people think morphine is not a good drug. The fact is it is the best drug for severe pain. There's nothing better right now. Certainly with cancer pain patients, there's nothing better. But there are many people who have severe pain that require opiates. So how do opiates work? Well, in its simplest description, when someone takes a drug systemically, in other words, orally or injected into the muscle, the drug goes to the brain. And when it goes to the brain, it turns on a system that uses that takes advantage of the brain's endorphin system. It's the same system. Morphine basically hijacks that system. And what it does is it shuts off the message from ever getting to the brain. So the hand brings the information to the spinal cord, and the morphine eventually shuts off that transmission. Pretty straightforward. So what's wrong with morphine? It's a great drug. What's wrong with it, of course, is it has tremendous side effects. That is the problem with many good drugs, is what we call the therapeutic window. The part that's good is there's a lot of things that are bad. In its worst case, it can kill you because it can shut off breathing. It can produce constipation because there are targets for the morphine and other opiates like oxycodone in your gut, and that's why you take drugs when you have diarrhea, because you're effectively trying to induce a kind of state of constipation. But when you're taking lots of opiates, too much constipation is impossible to tolerate. And of course, there's the big problem of psychological dependence. Indeed, some people will perhaps move to more drugs. Some people will end up moving to heroin. And there have been some horrific stories that we're all aware of now. And these things need to be addressed. But we don't want to throw the baby out with the bathwater. The fact is that opiates do have an important role to play. Can we minimize the side effects? Well, here's where basic science has made another huge impact. It was shown initially in animals and then in humans that if you inject the morphine directly at the level of the spinal cord instead of in a way that'll go to the brain, you can block pain without many of these side effects. So this is an approach that science has taught us and hopefully will make a big difference. So what other approaches are available? There are many, and you'll hear more about these in the subsequent talks. But clearly, new pharmacological targets, transcutaneous electrical stimulation, placebos are effective. If somebody responds to a placebo, it doesn't mean they don't have pain. Alternative therapies such as acupuncture, hypnosis, all of these are approaches that can be used. And what they emphasize is that there is no pain pathway that can be cut, but if you take advantage of the fact that there are different components to the pain experience, including cognitive and emotional components, then you need to target all aspects of them. And I think Kristen will be talking about that later, which is probably why pain clinics take a multimodal approach. There's not one holy grail magic bullet that's going to block everybody's pain. You need to be aware of its many dimensions. And so with that, I'd like to turn the podium over to Mike Robotham, who will tell us more about clinical perspective on the pain patient and approaches to management and problems.
Hi, my name is Mike Robotham. I'm going to present some slides on clinical research related to pain treatment, pain mechanisms, and pain research. So on my agenda, I want to talk about types of clinical research, the placebo effect, a very controversial topic, opioids for chronic pain from a research perspective, and then on biopsychosocial aspects of pain. There are many different types of clinical research on pain. I'm just going to touch briefly on a few different kinds. One is mechanism-oriented research, which are studies designed to learn more about how pain develops and how it's maintained, but not to test new treatments. And a number of different modalities are used in conducting these studies, such as brain imaging, testing devices such as EEG or EMG nerve conduction studies, or quantitative sensory testing. It may involve taking blood or other samples and sometimes doing provocative testing seeing what factors either ameliorate or aggravate the pain. A second kind of research are what are called observational or natural history studies, where again no treatment is involved, but patients are observed over time with chronic pain to see if the pain gets better, gets worse, and how it changes. Translational research may involve healthy volunteers using experimental pain models designed to mimic some aspects of the chronic pain experience. And they may link imaging, biomarkers, or questionnaires to try and improve strategies to predict treatment outcome. And then finally, I'll spend most of the time talking about clinical trials and especially why placebos are used in clinical trials. So first, let's talk about pain mechanisms, dividing pain into categories. So I show three types here. Nociceptive pain, which is pain caused by activity in neural pathways in response to potentially or actually tissue-damaging stimuli. So these are things like postoperative pain or arthritis, acute mechanical low back pain, sports and exercise injuries, and some less common conditions such as sickle cell crisis. This is a situation where the pain pathways are essentially working in a normal fashion because there's actual or potentially tissue-damaging stimuli that are taking place. At the other end is neuropathic pain, which is initiated or caused by a primary lesion in the nervous system. And one type of disorder that I'll talk about in some of the slides I'm showing is postherpetic neuralgia, which is a type of nerve damage pain that follows an outbreak of shingles. Others are neuropathic low back pain, such as from damage to things like the nerve roots, pain following a stroke, pain following are associated with peripheral nerve disorders, like from diabetes. There's the single most common one. And then disorders that are less common, like trigeminal neuralgia or complex regional pain syndrome. And in the middle, I show what are called mixed types, which is a combination of tissue injury and neural injury. And probably the best example of that is acute herpes zoster, because this is a neurotropic virus that when it reactivates and eventually manifests itself as the shingles rash, the virus is being transported down the peripheral nerve to the skin, and in the process is creating intense inflammation and damaging nerve fibers. So you have a combination of both inflammation and nerve damage. So there are many ways in research to probe the pain generators. So I mentioned before things like brain imaging or monitoring devices. There's some other ones such as taking blood or other samples, and what I show here in the middle image is a 3mm skin punch biopsy. This is basically a very tiny version of an apple corer. It takes out a small little plug of skin, and then it can be looked at under the microscope after being stained with special stains to find the nerve fibers in the uppermost layers of the skin and determine if the nerve fibers have changed the way they look, if they're expressing different molecules on their surface, or if there's fewer of them than normal. The lower left-hand image is a probe that heats up or cools down using a computer control for doing quantitative sensory testing. And on the lower right is what we call the capsaicin response test. So you put a small amount of over-the-counter capsaicin in an area where nerve damage is taking place, and you look to see if that alters the characteristics of the pain and how the sensory examination changes. Now, in an observational or natural history study, the main questions are things like, does this pain ever go away? And as I mentioned before, it's not intended to directly test how well a treatment works, but patients are able to, are allowed to be undergoing treatment during these studies. The advantage of this is you can learn more about whether or not pain will get better on its own, whether or not the invasive or complicated types of treatments are justified. And you can compare more crudely different groups of patients receiving different treatments. So the illustration here is from a study looking at the average daily burden of pain in patients who've had shingles in a natural history study. What this slide shows is that patients with severe pain during acute shingles and patients with less severe pain during acute shingles both recover at about the same rate, but the ones with a more severe initial pain take longer to become pain-free. Now let's turn to clinical trials. This is the most powerful way to find out if something works. And there's many different types of clinical trials, which we don't have time to go into here. But the key factors are they're prospective. In other words, you start the experiment with a definite time point and rolling subjects, and then you gather the data as the subjects go through treatment. Patients are assigned randomly to treatment, essentially like by the flip of a coin. And the purpose of the protocols is to try and eliminate all potential sources of bias. And the best ones are blinded, double or even triple blinded, where not only does the patient not know what treatment they're getting, but the people administering the treatment in the clinical trial don't know either. What's shown here in the graphic is a published graph from a study of the antidepressant duloxetine for diabetic neuropathic pain. And what you can see here is that the top line in the yellow-orange color is the placebo group. Their pain doesn't go down very much, but the groups getting the 2 different doses of duloxetine have an improvement in pain by about 3 points on a 0 to 10 scale, and they maintain that for the last 7 weeks of the 12 weeks of treatment. Now, why would a placebo be included? Well, in essentially all trials of new drugs, and especially when the drug acts in new or unique ways, a placebo is necessary, and this is ethical because it reduces the number of people who have to be exposed to the risks of a new treatment in order to be sure it actually works. Later studies may then compare the new drug against more standard treatments. The placebo effect itself is really quite variable, and under the right circumstances, almost anyone can be a placebo responder. So here I have some references to studies that show some unusual aspects of placebos in clinical trials. So the graph on the right is data taken from randomized controlled trials showing how pain changes over time under placebo treatment. And what you can see is that as one looks towards the right side of the graphic, the pain scores are continuing to improve even at 12, 15, or 20 weeks of treatment. So what that means is that the placebo seems to be working better and better over time. Now that may just be the natural history of the pain disorder, and it may be the environment of the clinical trial situation, but it's something that's associated even in the patients who are just getting a placebo. The second study that was really a landmark in this area is a study by Federle and colleagues in 1981 showing that a placebo can lose its effect over time on repeated exposure. And this was a study where placebo responders from an initial evaluation session were then recruited into a 4-month-long double-blind comparison of placebo and the non-steroidal anti-inflammatory drug naproxen for painful dysmenorrhea. And what they found in that study is the first monthly cycle, the women had 84% of them responding to placebo. But by the time they got to the 4th cycle, placebo really had completely stopped working, and that many of the women had actually dropped out of the study. And of the ones who stayed in the study, only 11% continued to respond to placebo treatment when they received it that month. And then the table on the lower right is data also from a very old study, 1981, showing that a placebo works better if it's the right color or it comes in the bottle with the same labeling as your usual pain reliever that you think works well for you. And what this shows is just the power of branding and other aspects of how a medication is given to you in how well it's perceived to be working. Let me turn to opioids for chronic pain from a research perspective. And I think the bottom line here is that opioids work at least as well as any other medication category, at least at first. Patients generally don't like taking them, and would like to stop. Many patients do this on their own, and sometimes abruptly enough to go into obvious withdrawal. I think it's well established that clinical trials of opioids for pain have the highest dropout rates of clinical trials for pain. And here's a quote from 1870 talking about the potential of drugs like morphine to actually, over time, make the pain appear to be worse than it was before treatment was started. This is something that later was called opioid-induced hyperalgesia, which is still a controversial concept, not fully proven. And the clinical trials of opioids can be very hard to interpret. We don't know how quickly tolerance develops, but it probably takes at least 5 days for the pain-relieving effect to start to really diminish. What I've shown here in the graphic are two studies. One is a crossover study conducted by Dwight Moulin and his colleagues and published in Lancet a number of years ago, where patients were given placebo and then crossed over to morphine, and the other group received morphine in the first treatment period and then crossed over to placebo. This was an unusual study in that in the first several weeks of treatment, the patients were allowed to go up on the dose in order to find the optimum level of pain relief, and then the dose was fixed. So what you can see is that pain scores go down in the group receiving morphine in the first block, but then once the dose is fixed, they start to lose that improvement in pain relief. The right panel shows an human experimental pain model study done in healthy volunteers, showing that the reduction in pain in an experimental pain model seems to begin to significantly diminish by the 4th day of receiving that medication compared to placebo. Opioids for chronic pain. I would comment that the doses used in clinical practice are definitely beginning to come down, and this may turn out to be of some help in reducing prescription drug abuse, but we just don't know yet. Clinicians and patients both would definitely benefit from better education about opioids. Simply put, they're not as good for pain as some would have you believe, but they're also not as bad a treatment for chronic pain as some would have you believe. I list some resources here related to opioid prescribing. And let me close by talking a bit about the biopsychosocial aspects of pain. The one problem that we have as researchers is there are no reliable biomarkers. We can't see pain. And animal models tell us a lot about the process of nociception and brain and spinal cord pathways, but they don't really tell us much of anything about the biopsychosocial aspects. As one patient I saw early in my career told me, to have pain is to have certainty. To hear about pain is to have doubt. I show a slide here from a company called No-Lie MRI, where they claim to be able to do the MRI equivalent of administered truth serum, but this, of course, has a lot of problems with it, and there is no equivalent of a no-lie MRI as to whether or not somebody is really experiencing pain. We have to take their word for it. From the patient perspective, pain changes them. And from the physician perspective, it's too often that patients had problems to begin with, or that they have a hidden agenda that they just haven't told their physician about. In summary, there's many types of pain and many types of research. Pain research is severely under-resourced, and clinical trial failures and a lack of biomarkers have reduced the industry interest in developing new treatments. Placebos and sham therapies are necessary evils in developing new treatments because they do increase the efficiency of the studies and reduce the number of people exposed to the risks of a new therapy. Opioids are helpful, but it's a two-edged sword. And research on biopsychosocial aspects of pain are neither well understood or integrated into pain research as a whole. Thank you.
Thank you, Mike. And now I'd like to turn the podium, I guess, over to Chris Beasley, who will give us a very different perspective on the pain problem from someone who has experienced it, but somebody who is committed to advocacy for better pain research. Chris, welcome.
Thank you, Alan. I'm co-director or co-founder and director of the Chronic Pain Research Alliance. We're one of very few groups in the U.S. that's working to increase the federal investment in pain research, and I'm going to talk a little bit why that's so needed in my upcoming slides. So today, just briefly, we're going to talk about the human and economic impact of pain, and again, the urgent need to invest in pain research. As Alan eloquently described, pain is subjective. It's individualized. The experience of pain is subjective and individualized to every person. There's a sensory, an affective, and cognitive component to pain, which you can see in these in this artwork provided by painexhibit.org. Everybody experiences different types of pain in terms of what it feels like. It can be aching, throbbing, stabbing, burning, pins and needles. Everybody has a different affective component to what they experience. And it affects us all differently psychologically and socially. And in addition to that, you can see this is a diagram of a pain patient who shaded in areas where they're experiencing pain, and also you can see around the head wrote in fog and wrote, "The pain is bad enough, but I can't think straight either. My family can't count on me, and I can't count on myself." So pain expands far beyond just what we experience physically or biologically. It has a huge impact on our day-to-day lives and our ability to function. We know from a major study of the Institute of Medicine in 2011 that pain affects 100 million Americans at an annual cost of $500 billion. That's more than the combined cost of cancer, heart disease, and diabetes. Some additional major findings from the Institute of Medicine report, Relieving Pain in America, is that chronic pain can become a disease in and of itself. That effective pain management is a moral imperative, professional responsibility, and the duty of people in the healing professions. And that to reduce the impact of pain and the resultant suffering will really require in the U.S. a cultural transformation in how pain is perceived and managed on both the personal and societal levels. And that although significant advances have been made in the understanding of the basic mechanisms of nociception and pain, we have huge data and knowledge gaps in pain research that remain, and these have prevented these advances from being translated into safe and effective therapies for patients. So if you look at what the United States is investing, the federal government is investing in research on chronic pain right now, and you look at it in terms of a prevalence comparison, as we discussed, pain is as prevalent as diabetes, heart disease, and cancer combined, which has a prevalence of about 100 million people. You can see on the left, compared to the right, that the National Institutes of Health is investing 95% less in research on chronic pain than it is on these other conditions combined. And then when you look at it in terms of a cost comparison, as Alan mentioned in the beginning of his talk, you can see how drastically chronic pain research differs from the other conditions that are listed in this graph, such as heart disease, diabetes, Alzheimer's, cancer. That even though we are spending, or that chronic pain costs the U.S. $500 billion each year, that we're really investing only about $400 million in chronic pain research. So what does that equate to in terms of the human being that suffers from pain? For each person in the U.S. adult that suffers from chronic pain, that's an investment of about a nickel per person. And this has a huge effect on not only patients but clinicians. This is a quote from a paper, recent paper in Lancet, that said, "The past decade has seen advances in our understanding of the mechanisms underlying pain," as we've heard both from Alan and Mike's talks. However, the current available treatments provide modest improvements in pain and minimum improvements in physical and emotional functioning. The quality of the scientific evidence is mediocre and has not improved substantially during the past decade. So what does that mean for patients and clinicians? Since we have very little evidence and the translation of what we've learned in basic science has not been heavily translated into evidence or information that clinicians and patients can use to make informed decisions about care, what we've seen is an explosion of therapies available for chronic pain without very much evidence attached to them. So we really don't know right now what works for whom, in what situations, and at what risk and with what cost. And this is a conundrum, not just for patients, but for clinicians as well. When you have a patient who comes into your office and you want to help them, we're looking to have the data and the evidence that's there that's going to tell us, clinicians can say, you have a good chance of improving with this therapy or this combination of therapies. Right now, we really don't have a lot of information that informs those types of discussions. And so when we ask patients about what pain research means to them, what their perspective is on pain research, we asked about what is a declining pain research effort, what kind of words come to mind, and the overwhelming response was hopeless. But you can also see in this word cloud, people said things like frustrated, fearful, doubtful, angry, dismal, scared, death, sad, despair. This is the human, real translation of what knowledge and advancement of knowledge and research means to the everyday person. And when we ask patients, what does an expanded pain research effort mean to you? The overwhelming response was hope, the opposite of hopeless, with other words such as pain-free, cure, better, crucial, finally, grateful, relief, needed, excited, life, thankful. So there's an urgent need now, especially with an aging population, that we really cannot afford to invest poorly in pain research anymore, not just from advancement of knowledge and improvement of our economic situation, but what that means to the everyday average person that's suffering from chronic pain and looking for the answers that they need and deserve to have a good quality of life and to be able to contribute back to society. So we thank you for your attention to our presentations, and I believe we're going to move on to some question and answers.
Well, thank you very much, Chris. Now, the way this is arranged is there's an opportunity for folks listening to send in their questions through the chat room, I guess it's called. And if you can please write your questions, and we will do our best to answer them. And so do we have a first question? How can we explain pain to patients and clients? Well, that's an excellent question. I think listen to the webinar. The fact is that pain is, on the one hand, a warning signal. The body protects itself, and we receive information, the brain processes it, and it says, that's bad, you want to get away, pull your limb away, you don't want to burn yourself. What's much more difficult is to understand that chronic pain is in many ways, although it's a symptom of many conditions, and particularly in the case of neuropathic pain, it really is a disease of the nervous system. There are changes in the brain that take place, and an individual has persistent pain. And understanding the nature of those changes and being able to reverse them is really the approach to pain management in the future, rather than just trying to treat pain as a symptom that needs to be eliminated.
Yeah, I would also add to that a very popular way of discussing and fitting way of discussing chronic pain and pain today is the biopsychosocial approach to pain. So understanding that there's a biological side of pain, what your nervous system is doing and how your other body systems are contributing to that. There's a psychological side of pain. We all experience it differently. We all associate pain with different things, and there's a social perspective of pain. And that really, in order to effectively understand pain and to treat pain, we need to address each of these components.
Right. There's a follow-up question that's in a sense along the same lines as why does long-term chronic pain persist even after the cause has been healed, and how can we teach the brain that it no longer needs to produce pain sensory alarms? That's a very difficult question. There are certainly instances in which when the injury has healed, pain can persist. That tends to be more the neuropathic pain type condition. But most pains will persist. We tend to think of chronic pain as something that lasts for at least 3 months. Post-operative pain could last for weeks to months, to a month or so, and then it will usually heal. Going back to my comment earlier that the nervous system is not a static processor of information like a telephone. It actually changes. When injury persists, there are new genes that are synthesized. There are new connections that are made. There are connections that are lost. Many conditions arise because inhibitory controls that are so important in damping down too much input get lost or destroyed. And so in a sense, you're dealing with an individual whose brain has experienced chronic injury is not the same brain as the individual who hasn't. And so the reason why pain can persist is that you basically have an altered central nervous system. And understanding what drives those changes and hopefully reversing them is really the way to deal with the problem. We have another question. With pain management, how can we increase the quality of life? No question that quality of life is the ultimate goal. I will turn this question over to Mike and Chris. Mike, some thoughts on that?
On quality of life?
Yeah, if you're dealing with a patient with a major pain problem, and so you could try to deal with as I said, the sensory discriminatives. You could try to block the pathway with local anesthetics, but you're dealing with an individual whose life has been affected, and to what extent is the clinician responsible for dealing with the quality of life deterioration that characterizes the chronic pain condition in that individual?
Yeah, I'd say from my perspective as a clinician, that's really the biggest task that the clinician has, is to not just try and reduce or fully relieve the pain, but also to help the patient find ways of coping with its ongoing impact on their quality of life, and try and help them maximize it, because it just has such potentially devastating effects on relationships with other people, ability to work, and just all sorts of things.
Chris, any thoughts on that?
Yeah, I would add, and also tying into the last question about, once a person has chronic pain, how do you retrain yourself to understand, acute pain is a warning signal to us. So as patients, as individuals, when we experience pain, it alerts our brain that something is wrong and we need to do something different. In chronic pain, it's the opposite. So we understand that there is a process going on within the body that's not maybe completely understood, but that we have to retrain ourselves to have quality of life while we're still experiencing pain, and understand that there isn't necessarily, it's not serving as a warning signal anymore, and it's actually counterintuitive. And with pain management, as I discussed in my presentation, although we don't have a lot of evidence to say which treatment is going to necessarily be the most effective for you, the good news is that there are a lot of options out there in terms of treatments that you can try. So it does take time, but most people are able to find a combination of treatments that work for him or for her to increase their quality of life. And what we've become to understand recently is that it's not just pain that we need to address, that there's other affected domains that go hand in hand with chronic pain, such as sleep and mood, fatigue, physical function. And so we need to understand the major pain management approach is to understand which of these domains are affected in a pain patient. So if somebody's not sleeping well, if they have depression or anxiety, if they're not able to get out and exercise or engage in social activity. We really need to develop a pain management strategy that's personalized to each individual to address not only the type of pain they have and where it is in their body, but all of these other areas that are affected. And that's really a holistic approach to pain management that can help take people from a chronic, devastating painful state to having an increased quality of life.
Well put. There's a very interesting follow-up question, not a follow-up question, other questions is how can we deal with pain using augmented reality and virtual reality technology? Now, on the one hand, I will tell you that I have no idea. On the other hand, I will encourage everyone to go back to their web and pull up a Terry Gross program, and where just very recently that she interviewed a writer who's written a book, a reporter and writer from Britain, who's written a book on, I guess, psychological approaches, different approaches to dealing with pain in particular, placebos, and she specifically addresses virtual reality, and to a great extent it has to do with distraction and being just in another world where you don't focus and spend all your time thinking about your pain. The real question that I had when I heard that very interesting interview was whether there's any persistence to the effects that occur while you're in a state of using the virtual reality machines. I don't know if the others have thoughts on that, but I certainly encourage people to listen to that podcast.
You know, it's an area that is hopefully will really start to take off as the devices get better and become less expensive, is to try and develop specialized rehabilitation programs for chronic pain that make use of the ability to immerse the pain patient in a completely different experience, and one in which they either have no pain or they're physically able to do things that their pain has been limiting them from doing. And research is just really getting started in that area now, I think.
Thank you. So here's a question. Exactly why has pain survived evolution? Why is pain necessary to our survival? Heavy question. I think one could argue that acute pain certainly has evolutionary value. You're injured and you need to avoid the injury. If you are completely unaware you don't experience pain, then you could be like the individual who has congenital insensitivity, or also called congenital indifference to pain. I spoke of the NaV1.7 sodium channel mutation. Clearly, these are individuals who have major problems because they never experience pain. So I don't think we have a problem understanding the value, the evolutionary value of acute pain. In my own mind, I see no value, evolutionary value, to chronic pain. Once you're aware you have cancer and you have ongoing pain, good. I've been told I have cancer. I'll go to my physician and I'll try to deal with it. But remember, if you think of this as a disease, as pathology, then there really is I don't see any value to chronic pain at all. I don't know if the others have thoughts on this here. Guess not. It's a tough one. So we'll go into another question. What allows for pleasant thoughts to buffer pain? I'm going to pass this one on. Anybody want to handle this one? I mean, I would certainly say it's a distraction element again, but Chris?
Yeah, absolutely. That's what I was going to say, is that, part of, again, the multimodal approach to chronic pain management, and also talking a little bit about personalized medicine, is that each of us are different. Our brains are different. Our perception of pain, our experience of pain is different, and each one of us will, if you talk to any chronic pain patient, will tell you they have a toolbox of things that they use on mediocre days and bad days to help them deal with, the severity, intensity of pain, but also the cognitive and affective components of pain. And certainly distraction, pleasant thoughts, positive thinking, resilience, these are things that are starting to be explored in science, but there is a biological basis for these things. When a person is engaged in pleasant thoughts or things that are bringing joy to their life, it's a distraction. It helps them concentrate on the future, the positive, the things that are good in their life, and it can actually serve as a distraction to pain. So that's definitely one important part of a toolkit that each person would use to manage their chronic pain.
There's actually a very interesting set of experiments recently reported by Frank Perepka at the University of Arizona. And he's, of course, people are very aware of dopamine as a positive reward signal, that when there are pleasant events happen, when there's rewarding events, dopamine is released in the brain, so it's a very positive neurotransmitter. Well, it turns out that what Frank's group has shown is that when pain is relieved, there is a dopamine surge. So relief of pain is rewarding. And so to the extent that relief of pain is a good thing, which obviously we would agree it is, to the extent that dopamine can be increased concurrently, that is obviously, or may, make the experience of pain reduced, whether or not the actual stimulus was changed. So if you experience pleasant thoughts, or you go to a good movie and you're distracted and you're feeling good, it makes sense if that dopamine surge could conceivably counteract the negative aspects of pain. This is at the basic science level, but this is precisely the types of questions that people are beginning to get at the much more complex pain experience than just how does an injury stimulus get transmitted. Here's a rather very relevant question these days. What is the importance of genetics in chronic pain development? Mike, I don't know if you want to talk a little bit about that. It's certainly relevant in the case of certain migraines, but I don't know to what extent this has become influential in the clinic, or is it just some isolated examples to date?
Yeah, so I think as a field, the pain field still suffers from a lack of biomarkers. There are a few pain syndromes and migraine that have been tied to specific channel abnormalities, mostly in sodium channels. But thus far, that hasn't really turned into a biomarker test or a screening tool. And then I think after that, because pain is something that can be a maladaptive response to a tissue injury, and is something that evolution has not gotten rid of, to get back to the earlier question, it really gets to why does it persist in that particular patient and what are the impacts of it. And those are questions that don't really lend themselves very well to the kind of biomarker approach that's being used in cancer and certain other neurological diseases. So the long answer to the question is that genetics is still understudied for pain, and that it hasn't had much impact on how pain is actually treated yet.
Yeah, one tends to think of pain as such a complex experience that nobody really believes that there's going to be any single gene that explains why somebody experiences a lot of pain versus someone who doesn't, and there obviously are differences. I'm encouraged to some extent by just the report that is appearing in Nature about a gene that predisposes, it appears, for schizophrenia. A very exciting series of studies, and this gene seems to be linked to the loss of synapses in a particular part of the brain. Now, why is this relevant to the pain experience? Well, schizophrenia is such a complex condition that, again, one didn't think that one particular gene would be so relevant. However, loss of synapses and disrupted central nervous system connections, as I mentioned earlier, has been implicated in some chronic pain conditions. And so it's not inconceivable that we may find that certain genes do predispose. We do know that certain genes can predispose someone to be more sensitive to opiates or less sensitive to opiates. So this is a field that is burgeoning. There are several laboratories around the world that are looking at this. but I think it's true that it's still a little early, and there's no real connection yet in general to the pain problem in genes.
Yeah, there is some work on pharmacogenomics, that genetic influences on how well you absorb and or how well you metabolize a drug and blood concentrations, but those are really not getting to the source of pain or really necessarily the overall responsivity following with a specific category of treatment.
Mm-hmm. So here's a very important and difficult question. Comes from, I believe, a nurse, from an emergency nurse, room nurse, who asks, are there new treatments away from opioids that tend to be only CNS, which she believes are only, she writes, are only CNS depressants and non-effective anti-inflammatory medications? I should point out that I don't know that this is a male or a female nurse. So the question is, opiates, as I mentioned, are often the drug of choice for very severe pain, but they have side effects. So what other approaches where's the field going, I guess?
Do you want me to field that one, Alan?
If you can, sure.
Yeah, the problem has been that there's been a lot of drugs that are targeting new pathways that haven't been investigated before, and the drugs will fail in phase 2 trials, or a few make it to phase 3 and then fail. So that's led to very few completely new and novel compounds entering the field in recent years. For the most part, we're still working with the same small list of drugs, the gabapentin and pregabalin compounds that work on, are thought to work on a calcium channel subtype in the central nervous system. They do have sedating and depressant qualities. The antidepressants, which also tend to produce a variety of different changes and are centrally acting with some small peripheral effect. And the opioids, which also are primarily acting in the central nervous system. For nerve blocks and other kinds of interventions, those are usually working in the peripheral nervous system, and they have their advantages and disadvantages. The advantage is that they don't require large amounts of drug going into the central nervous system. The disadvantage is they are expensive and invasive, and the benefit tends to be short-lasting. So I think that's really the holy grail now, is to come up with drugs that are effective but without CNS depressant effects.
I think it's worth mentioning, and because of time, I didn't have time to get into it in my presentation. There are, and it really segues nicely from what Mike just mentioned, for osteoarthritis and other inflammatory pains, something on the horizon that is still in phase 3 trials, and there have been some phenomenally successful phase 3 trials, antibody approaches. Now, antibodies are rather large compounds, and one in particular, an antibody against something called nerve growth factor. Nerve growth factor is a molecule that is released in settings of inflammation. So the antibody is given, and what it does is it sops up, it recognizes the NGF, the nerve growth factor, but it's so big that it can't get into the brain. And that immediately reduces potential side effects caused by CNS action, which would include depression. And this is, it's not completely without side effects, but the results to date have been really quite remarkable for inflammatory conditions. Another one on the horizon is an approach to treating migraine, also with an antibody, and in this case the idea is to regulate the vasculature, the amount of dilation of blood vessels that occurs in migraine, again with the hope of not getting involvement in the brain. So I do agree that approaches that target the drug to the area where the problem is and keeping it out of the central nervous system is the approach. There will be side effects almost always because the nervous system the body tends to be conservative, and the same targets, same molecules are used over and over. But restricting the distribution of the drug is definitely an approach that is is on the horizon. And we have a last question. How can we, as the general public, help encourage more pain research? I'm going to turn this one over to Chris, because I almost have a conflict of interest there. Chris?
Yeah, thank you, Alan. I mean, this is a huge issue, as we discussed throughout the presentation, that pain has typically been viewed as a symptom, not a condition, but that once a person has maladaptive chronic pain in their body, that it can become a condition in and of itself, a disease in and of itself of the nervous system. And certainly this needs to be understood by the general public, that we're dealing with an enormous problem that affects a huge number of people and at a high cost, not just economically, but the human cost and toll. And the way that funding gets allocated in our country is somewhat of a mystery to most people, but typically we need to have a large public outcry of importance of a condition to gain understanding and priority within our federal process and federal research investment allocation. So it's important for people who have pain, for people who know people, friends or family members who have pain, that you're speaking up about it and the importance of investing in research on it. You can do general things like writing your congressperson, alerting the media, and to join in efforts like those with our organization, the Chronic Pain Research Alliance, to add your support and your voice to encourage more pain research that goes on in the United States. If you visit our website, chronicpainresearch.org, and click on Advocacy, there's an Advocacy 101 section that talks about more specific ways that you can join in the effort to make your voice heard, to communicate the importance of addressing pain in our country, and to advocate for more pain research.
Well, I couldn't have said it better. I really do encourage everyone listening to be more aware of the need for improving and enhancing and increasing pain research funding. It's still a big problem. Progress is being made, but the problem is huge. So with that, I want to absolutely thank Mike and Chris for joining me in this webinar, and particularly want to thank the BrainFacts.org members and the American Brain Coalition for co-sponsoring this webinar. We look forward to hearing from people who have other questions, and keep your interest in the subject. It's an important one, and thank you all very much.